Good morning all. Now we'll start our next session, IC and ROP. Retinopathy of prematurity is a potentially blinding disease because of the abnormal development of retinal blood vessels in the periphery. Even though the stringent treatment options available now, ROP is a leading cause of childhood blindness because of the neonatal care is developing in the NICU, and all these preterm babies are not getting screened properly. So now I want to enlighten the crowd regarding the importance of screening. So we have evident speakers from all over India, and I'll invite Srita Madam to invite the speakers.
Good morning all. Today's first topic is pathogenesis and predictors of ROP by Dr. Meena C.K. Madam is pediatric ophthalmology consultant at Madam. Surgeries will do it in the end. Madam is pediatric ophthalmology consultant at Little Flower Hospital, Angamal. Over to you, Madam.
Good morning, everyone. At the outset, I would like to thank KSOS and Dr. Sheera for this opportunity. This is purely theory, pathogenesis and predictors of retinopathy of prematurity. As all of us know, the retinal vessels develop from the optic disc by about 16 weeks of gestation, and it reaches the nasal aura by 32 weeks of gestation, and the temporal retina is vascularized by 40 weeks of gestation. When the fetus is in utero, it is in a hypoxic state. That is, the stable partial pressure of oxygen in the arterial blood is about 22 to 24 millimeters of mercury. So it is in a hypoxic state, but it has got that advantage, that is, it stimulates vascular endothelial growth factor, which in turn stimulates retinal vessel growth into the peripheral avascular retina. So when the child is born into a high oxygen atmosphere, so there's a sudden change from the hypoxic state to the hyperoxic state. And especially when the child is born premature, there is supplemental oxygen being given for the well-being of the child. That itself will increase the risk factors. So the child from the hypoxic is going into a hyperoxic state. So what happens then? So this is the phase 1 of ROP. That is the first phase. What is happening is that the retinal blood vessels are reacting to the hyperoxic state by causing vasoconstriction, and naturally there will be a down regulation of the vascular endothelial growth factor and insulin-like growth factors, and subsequent to that there will be cessation of the retinal blood vessel growth. So first there will be a cessation, that is phase 1, usually occurs in 22 to 30 weeks of post-conceptional age. Now once this vasoconstriction occurs and there is an avascular retina there. So this retina is starting to mature, and it needs oxygen, and there is no vascularization. So naturally there will be a stimulation for VEGF and insulin-like growth factors. So these factors are being produced. So when the avascular retina is minimal, then there can be only a physiological change, that is, all these VEGF will help for the vessels to grow into the periphery. But when too much of avascular retina is there, you can have abundant growth factors, and that can be dangerous, and it causes disorganized retinal vascular growth. And this occurs mainly at the avascular and vascular junction. And along with that, you can have damage to the existing vessels also. When the avascular retina is when the size of the avascular retina is more, then even the existing vessels can be affected, and this results in the aggressive retinopathy of prematurity, where there will be dilatation, tortuosity, hemorrhages, and which is the most dangerous condition that we have to treat immediately. Now coming to the predictors of retinopathy of prematurity, there are a number of predictors have been mentioned in the literature, but the predictors that we are aware of, or what the neonatologists tell us, are mainly the low birth weight and gestational age. As all of us know, as the birth weight reduces and the gestational age reduces, the risk factor is extremely high. And oxygen, as we know, is another single most important risk factor. And VEGF is the most intensely studied angiogenic factor, considered to be the central player in both physiological and pathological angiogenesis. Insulin-like growth factor, it is a non-oxygen regulated factor, and clinical studies indicated that there is an inverse relationship between IGF levels and severity of clinical ROP. And all these we know that if there is bacterial and fungal sepsis, the child is more prone for ROP, and the length of the hospital stay and longer length of initial hospital admission obviously will be associated with higher rates of ROP. Human milk has been found to have protection against ROP, and patients with low platelet count that even we have seen, like they come with more hemorrhages, seem to have a greater risk of developing severe ROP. Now, association of erythropoietin, it has been found that exogenous erythropoietin protected the retina in phase 1, but it worsened pathological vascular growth in phase 2. And this is also an interesting thing that high levels of neonatal HbA1c, they are a feasible biomarker for proliferative ROP, and low levels are biomarkers for non-proliferative ROP. Then comes all the experimental ones like lactate, urinary N-terminal, B-type natriuretic peptide, etc. So to summarize, hyperoxia followed by avascularity, followed by the proliferation, these are the steps that happen in the ROP pathogenesis. Thank you.
Thank you, madam, for that very informative talk. Next, I invite Dr. Sheera KR for the next topic, ROP screening, criteria, protocol, and methods. Dr. Sheera is working as vitreoretinal consultant at Aradhana Eye Institute, Trivandrum. Over to you, Dr. Sheera.
Very good morning to all. I'll be talking on screening criteria, protocol, and methods. Why this ROP screening is important in this scenario? Because it's a blinding disease, and identification of babies with ROP who all are at risk and likely to develop severe vision-threatening ROP is very important. Timely and early detection prevents undesirable sequelae and progression to an advanced stage. When we think about ROP screening, what all things we should know? I'm actually going into each of these steps, which infants need to be screened and when to perform the first screening, and what all are the screening methods, where to screen, how should be the management decision at each screening, and how stringent should be the documentation and communication. It's actually a very important step. And which infants need to be treated, and when should the treatment be done, and where to treat, whom to treat, and what all are the method of treatment, and how should be the follow-up, and how should be the long-term follow-up. These many things we should know properly before starting the screening options. Now first, which infants need to be screened? According to the Indian criteria, babies born less than 34 weeks of gestation and birth weight below 2000 grams, and babies with 34 to 36 weeks, even with risk factors, any of the risk factor if present, that baby needs to be screened. That is need of respiratory support, oxygen therapy more than 6 hours, sepsis, apnea, blood transfusion, exchange transfusion, or unstable clinical course. In the absence of reliable records, even a history of admission in the NICU is considered to be a surrogate risk factor, and that baby needs to be screened. When we compare to the screening criteria in the other countries, we can see in India it's a little higher limit, 34 and 2000 gram. But in India we have reported ROP which is vision threatening even in a little older babies. And next is where to screen and when to screen. All the screening should be done in a neonatal ICU, either in the step-down room, in the presence of a neonatologist, so that all the complications can be handled. But if the baby is already discharged, in such a babies can be screened either in the NICU when they are coming for the follow-up in the hospital, or can also be done in the ophthalmologist clinic. In the first screening of ROP should be performed within first 4 weeks of the life or in the admission period in the hospital. And if the baby is less than 28 weeks or the birth weight less than 1200 grams, such babies needs to be screened in the first 2 to 3 weeks to rule out the AP ROP. And coming to the method, the gold standard ROP screening method now also it's indirect ophthalmoscopy by a trained ophthalmologist. But other screening options are wide angle digital retinal camera, smartphone based screening and tele-screening approaches. How should be the dilatation? The dilatation of the pupil should be done with 2.5% phenylephrine and 0.5 to 1% tropicamide combination. It can be instilled 2 times 30 minutes interval prior to the examination 1 hour before. Or the other way is 1 drop of 0.5% tropicamide can be instilled at least 3 to 4 times within 1 hour. And in such a situation, phenylephrine single drop can be instilled 15 minutes prior to the examination. The thing we should be careful about is the phenylephrine repeated instillation should be avoided because of the complications. And anesthesia 0.5% proparacaine can be instilled before the examination. Along with that, oral 25% sucrose or 25% dextrose can also be given. That's especially in a case of laser, during ROP laser. And other sterile single-use pacifiers can be used, and lead speculum to reduce the discomfort, and scleral depression to stabilize the globe, to rotate and indent the globe. This is the gold standard method of indirect ophthalmoscopy. The baby should be properly wrapped and the indirect screening should be done. And next option is the wide field retinal photography. The main advantages are it's easy to use by the nurse or a technician, and it eliminates the inter-observer variability. It's a good teaching tool, and also it helps to explain to the parents, and it overcomes the logistics of screening, and it's more cost effective than examination, and the tele-screening is possible. Fluorescein angiography is also possible with this wide angle digital cameras, and it avoids the stress and the expertise of a IO examination and indentation, especially in a beginner. These are the wide angle digital camera options available. In that, Trinetra Neo gives 120 degrees of fields, and Redcam gives 130 degrees of fundus, and Optos ultra wide field camera gives 200 degrees of the fundus imaging. These are the few examples of Redcam imaging photography, the pre-treatment and post-treatment images. And the other option is smartphone based imaging. And the importance of tele-screening in India is, India with 1.3 million people has less than 1,000 trained retinal surgeons, and less than 150 of them are currently practicing the management of ROP. So with the majority of the rural areas devoid of such experts, wide field imaging helps to bridge this gap. And this fundus fluorescein angiography can be used with this various fundus cameras like Redcam and the Trinetra and the Optos, and it's safe in children and can identify the pathology even it's not visible with the indirect ophthalmoscopy, and can improve the diagnostic accuracy and more accurately monitoring the efficacy of the anti-VEGF therapy in ROP. And OCT and OCT angiography, it's not routinely done, but can give an idea about the lesions, and can detect it early also. And the popcorn lesions can also be detected early. And the management decision at each screening is follow-up examinations are routinely required at 1 to 2 weeks of interval, depending upon the ROP stage and the decision by the treating ophthalmologist. And urgent treatment usually required within 48 hours in case of an AP ROP case, and also babies with treatable lesions, vision-threatening lesions. And ROP screening can be terminated once there is a complete vascularization of the retina without any ROP, or if the ROP has shown complete regression by around 40 to 44 weeks of the post-menstrual age. And how should be the documentation and the communication? In the present era, this slides has got a good importance, because whatever we find, each examination, the findings, and how should be the follow-up, timing, everything should be documented properly, and also it has to be communicated properly to the parents without skipping the follow-ups. And when we record the findings, each examination, we have to detail the zone, stage, and extent in clock hours of any ROP, and the presence of any pre-plus or plus disease. This is an example for the chart how we can record the ROP screening, baby's date of birth, and birth weight, and the present gestational age at each examination, and the risk factors has to be mentioned in the initial visit, and on the follow-up visit we can record the findings and the further follow-up visit details. and the which zone is involved and stages, whether the presence of pre-plus or plus disease, and clock hours of involvement, and whether AP, ROP present or not. And also we have to record the anterior segment findings also, whether the media is hazy, whether the corneal haze is there, and similarly any hyphema or anterior segment findings also has to be recorded properly, and each visit, follow-up visit date, time, and where the baby has to come for the follow-up, everything should be recorded and communicated. And we follow this ICROP classification, zones, stages, and plus disease. It's already covered. And who all will need the treatment? According to the ET-ROP criteria, the type 1 ROP babies needs treatment. That is, any stage of ROP in zone 1 with plus disease, and zone 1 stage 3 ROP without plus disease, and zone 2 stage 2 or 3 ROP with plus disease. And AP ROP definitely needs treatment immediately. And in type 2 ROP, zone 1 stage 1 or 2 ROP without plus, and in zone 2 stage 3 ROP without plus, these babies needs close follow-up. And coming to the treatment options, next presentation will be covering in detail regarding the treatment options, laser treatment, cryo and intravitreal anti-VEGF injections, and the surgical options. How should be the follow-up after treatment? Post-laser and post-injection, close follow-up to be done with weekly follow-up, and may need further laser treatment also. And infants treated with the sight-threatening ROP are at a high risk for developing refractive errors, strabismus, amblyopia, myopia, cataract, and also retinal detachment, and they should be followed up until at least 5 years of age. That should be the long-term follow-up plan. Thank you.
Thank you, Dr. Sheera, for that very excellent PowerPoint presentation. Next talk is newer classification and terminologies in ROP by Dr. Manoj S. Manoj sir is the Chief ROP Consultant of Cradle ROP project at Chaitanya Eye Hospital, Trivandrum. Over to you, sir.
Thank you. Thank you, Dr. Sheera, for having me for the meeting here. Before I start, I would like to formally welcome Dr. Parag Shah. Dr. Parag Shah is our guest faculty from Aravinda Hospital, Coimbatore. I've done a lot of work on ROP, a lot of publications, and we're very happy to have you with us, Dr. Parag. So most of most of the things that I'm going to speak today are basically from his publication. So without much, so the international, I'll be talking to you about the international classification of retinopathy of prematurity, the 3rd edition, which is recently published in the year 2021. And the previous edition came in 2005. There are certain changes from that edition, and I'm going to stress on what are the new things that has come up in the classification. With regard to zone, there's not much of a difference. We all know about zone 1, zone 2, and zone 3, and there's not much of a difference with respect to the zones. But what they have defined is the zone, the posterior zone 2. The posterior zone 2 is a term that was already used by the previous classification, but there is no correct definition for it. And now this group has now defined posterior zone 2 as a zone of 2 disc diameter, which is outside the zone 1. So why this is important is because many investigators feel that the posterior zone 2 disease and zone 1 disease, they almost they behave similarly. Now the term immature vascularization or no ROP is a term we generally use loosely when we do not see the typical staged ROP. The ICROP has opined that we should do away with these terms and use the term incomplete vascularization. And so this is an example of an incomplete vascularization in zone 2. Now acute ROP is a term that is used to describe the staged ROP. So we have the stage 1, which is the demarcation line. You have the stage 2 where you have the ridge, stage 3 where you have extraretinal neovascularization, and stage 4 retinal detachment. 4A is when there is no macular involvement. 4B is when there is macular involvement, total retinal detachment, and plus disease. So all these come under acute ROP. Now they have defined a new term called notch. Notch is an avascularity which is kind of invaginating into the posterior pole. And the zone at which the invagination happens, that defines the zone of the notch. So this would be called as a zone 1 secondary to a notch. And the stage can be added, like this is a stage 1 disease, so it's stage 1. So similarly, this is a zone 2 secondary to a notch. So this notch is generally around 1 to 2 clock hours by definition, and it invagination, avascularity invaginating into the posterior pole. Popcorn lesions, this is not a new term, but then the controversy is, does this represent new vascularization or not? The ICROP3 clearly defines that this is not part of new vascularization, and these are seen posterior to the ridge, provided you don't see any other signs of stage 3 disease. Like in this patient, popcorn lesion is closely associated with the stage 3 disease. So this is a significant popcorn lesion. Stage 3 ROP refers to new vascularization. You can have them flat or elevated new vascularization. So the importance of flat new vascularization is more important now with the new definitions like hybrid ROP and in APROP. Now the problem with the plus disease in the previous old classifications, it was all based on standard photographs, and most of these photographs were narrow angle photographs or quadrant involvement. In fact, the previous revised classification talked about 2 quadrant involvement to call a disease as plus disease. Now the ICROP3 third edition talks about having more wholesome photographs involving the posterior pole. You look at both zone 1 and zone 2, and then presence of these dilated retinal veins along with tortuous retinal arterioles, which make up plus disease. Also, they try to differentiate pre-plus and plus. Now it's always difficult to call which patient as pre-plus and which plus is definite, but to call pre-plus always we have a confusion. So the ICROP group, they agree that there could be some confusion in the diagnosis, but they stress that this is part of a continuum. The disease evolves over a period of time, and therefore this difference will have to be kept in mind. Now the term APROP, this is a term that we are all familiar with. Now according to the previous classification, it refers to severe dilatation and tortuosity of vessels, which is out of proportion to the peripheral retina, and is limited to the posterior pole in zone 1 or posterior zone 2. So this was the definition, which is seen in extremely premature and very low birth weight. This is the exact definition given by the previous classification. Now subsequently, we have Parag has reported that these APROP children, especially in India, they develop in bigger babies, and they also reported that the gestational age of these babies may be more than 28 weeks. We also have reports from the PGH Chandigarh group where they've defined that these APROP they're not just restricted to zone 1 or posterior zone 2. They may be seen even a little more peripherally. So they defined what is called as a hybrid form of ROP, where these eyes are flat new vessels at the junction of the avascular and avascular retina, but they have ridges that are at different levels. Now this is a pattern 1 where you see a ridge at the junction of the vascularity and avascularity. Here you see the ridge posterior to the avascular and vascular zone. Here you see a ridge very posterior, close to the peripapillary region. So these are some variations where all these patients would fit into APROP. So considering all of these, the classification group said we should call these patients as aggressive ROP, AROP, and not APROP. So the posterior term is taken away. Now, in terms of retinal detachment, one thing new that they have talked about is a volcano detachment, the term that they've used to describe retinal detachment following an APROP. So in these patients, the macula is involved, the periphery is attached. So they said that they should still be called as 4B disease. And also they talked about the role of OCT in the classification. Now, this is a patient who looks like the macula is on, 4A, but if you take an OCT, you see there's a detached fovea. So sometimes on the basis of these investigations, you need to reclassify the disease. Regarding stage 5, the older classification said total retinal detachment can be classified as open funnel, open narrow funnel, and narrow open funnel and narrow funnel. This is based on the configuration of the retinal detachment. This is sometimes very confusing. The ICROP3 has come out with a very clear, easier classification. They said 5A when it's an open funnel, when you can visualize the optic nerve head. When you cannot visualize the optic nerve head, you call it 5B. It can be closed funnel or it can be just a retrolental fibrovascular tissue which is obscuring the view. And when it's associated with anterior segment problems, it's called 5C. So it's a very simplified classification. They also define the term ROP regression. Now that we have anti-VEGF, we see a lot of patients undergoing regression. So how do you define regression? So they said it could be complete or incomplete, it could be spontaneous or post-treatment, and this is characterized by resolution of the venous dilatation. The tortuosity of vessels may take some more time to happen. The first thing that you see is just resolution of the venous dilatation and regression of new vessels, of course. But you could also look at these peripheral signs. This is called as a circumferential anastomosis. This develops in these patients. And most of these patients now are incomplete in this sense. They have persistent avascular retina. This is called as SPAR. So these are the terms that they have introduced. They also introduced the term reactivation. This is very common with anti-VEGF therapy. With the injections, these eyes do well, but what happens 4 weeks or 6 weeks down the lane, they come back with a reactivated disease. So now you have a term for it, which is called reactivation ROP. As you can see here, this was the initial ridge. After anti-VEGF, the vessels have crossed the ridge and gone over, and now you have stage 3 disease happening at the edge of the ridge. And lastly, they have, I think, taken off the term cicatricial ROP and they've called it long-term sequelae. And this includes all the peripheral detachments, the peripheral retinal breaks, the retinoschisis, the macular folds, falciform folds, etc. So this is the term now that they've used. They also try to define what is the primary RD, what is the reactivation RD, what is the late sequelae RD. All of these are slightly different. So to conclude, this update has refined and added to the existing classification metrics, keeping in mind the present role of anti-VEGF therapy, the newer imaging tools. They've introduced new terms and categories, and these principles will provide a foundation for future research in clinical care and ROP. Thank you.
Thank you, sir, for the excellent talk. Next talk is by Dr. Natasha Radhakrishnan, Professor, Amrita Institute of Medical Sciences. Over to you, madam.
Good morning, all. So we have seen all the screening, classification, and the newer terms. Now we will go to what has changed in the treatment of ROP. So the challenges are that once there was the traditional treatment that we were following for many years, and then there was a paradigm shift when the anti-VEGF was introduced into the fray. And the management options have expanded, and yet there is an absence of consensus. And one management plan may not fit all the newborns, and there is lack of long-term follow-up for the newer modalities of treatment. So the evolution of the management of ROP is from the cryo ROP study from 86 to 96. In the 90s, everyone shifted from cryo to laser photocoagulation. Then we had the ET ROP, the revised IC ROP, and it was in 2008 to 2013 that the BEAT ROP and the Rainbow studies that came out and told us that anti-VEGF could be used in ROP. So I think this has already been covered, so we will not cover this. That is the treatment criteria that is given to us by ET-ROP. Now, what are our management options? We can do laser photocoagulation, we can give intravitreal anti-VEGF agents, we can combine both, or we can observe. When do we observe? We observe type 2 ROP. There is no change in that. And this is because, why do we observe? So we'll have questions asked by the bystanders usually. When you tell them that, no, we are going to wait and we are going to observe for some time. And that is because of this, because there is such a high incidence of spontaneous regression. Most of the studies show more than 90% incidence of spontaneous regression. So you don't have to laser every stage 1 and stage 2 baby that you see. And photocoagulation, of course, though we have a defined criteria for when do we photocoagulate, we really don't have studies that compared cryo and laser photocoagulation. But everyone just shifted to laser photocoagulation over the years, and it has stood the test of time. And it continues to be the gold standard. And it can be used in combination with anti-VEGF, as we will see later. What are the advantages? We have long-term experience with it. There is reduced breakdown of the blood retinal barrier compared to cryo. There is a longer interval between treatment and retreatment if needed as compared to anti-VEGF. There are some studies have shown that neurocognitive scores are better, and it is better suited for patients with accessibility and without who have financial constraints. The disadvantages are that it gives no possibility of physiological revascularization because it ablates the avascular retina. There have been field effects that can occur later on. Exudative retinal detachments can occur, higher post-laser myopic errors, and then, of course, some amount of reactivation also. So this is what happens when we laser. You can see that the avascular retina is lasered and the vascular retina is preserved. What are the practical tips for those of you who are practicing ROP laser? You can either complete one eye first and then break and move to the next eye so that you don't have to, so that you complete one eye and then move to the other eye, or you can practice it in that, whichever position you are in, you can do nasal of that eye and temporal of the other eye in that same position. And always put saline or antibiotic drops during the procedure. Usually we use saline to maintain the clarity of the cornea. The type of laser can vary from diode to frequency doubled Nd:YAG, and usually it takes about 20 to 60 minutes and depends on the experience of the surgeon. And nearly confluent burns is the difference that we do in ROP laser when compared to diabetic retinopathy laser, where we leave at least half burn width apart. Here, our idea is to ablate the avascular retina, and any avascular retina that you leave behind will secrete VEGF and cause reactivation. So there should be no skip areas, and the entire 360-degree of the avascular retina should be covered by your laser. It's a short video. I don't think you need to play the whole thing. I'll just play a little bit. So always, preferably you do it in the NICU, or you can do it in your OT if you have anesthetic backup, because the child needs to be monitored throughout the procedure. So it is always safer for you to do it in the NICU. As our Dr. Biju Raju has done always, he shows those videos, you can actually do it through the incubator as well. But most of the time nowadays with improved neonatal care, we actually don't need to do that. They give us support and give you, expose the baby to you for the laser. Next, we come to anti-VEGF agents. So what do anti-VEGF agents do? They target the hypoxic drive that is keeping this, neovascularization alive. And it is better suited to zone 1 and AP-ROP patients, as we have found out. It reduces field effects and post-intervention myopia. There is a less than 8% recurrence rate. There is a faster regression rate compared to laser. Faster procedure, hence less stress for the child. You can see the child wailing in that laser procedure. So here it gets over in less than 2 minutes. And perioperative role has also been tried in just before surgery. Now, currently, after the BEAT ROP and Rainbow trial, what are the indications for anti-VEGF? So you can use it as a primary therapy for zone 1 disease. You use it in aggressive ROP. You use it when there is a polydilating pupil and media haze making laser difficult. And if you have a failed laser treatment, either for retreatment or before surgery, you can use anti-VEGF. When should you avoid? If you think your baby has stage 4B and is in imminent danger of a traction detachment, do not inject at that stage, because you are going to hasten the process. And any other presence of significant traction, you should not inject anti-VEGF. The studies, we will not go into the details. We have the BEAT ROP that gave us bevacizumab is as good results as laser, and Rainbow, which gave the FDA approval for Axentrix, for ranibizumab. Now, practical tips during injection. SAFER is the acronym that we use. Use a short needle, the 32-gauge needle. Antiseptic or antibiotic betadine should be put prior and after the procedure. Follow up 2 to 7 days after injection to look for injection-related complications and to look for regression. And always maintain complete asepsis. If possible, you can shift to your OT, but most of the time these babies are extremely sick and cannot be shifted out from the NICU. You have to tell the NICU staff how important it is to maintain asepsis just prior to the procedure, and use the recently fumigated room in the NICU for the procedure. And ideally, you should do 2 eyes in 2 sittings and not in the same sitting. And the injection site is usually 1 millimeter posterior to the limbus in these children, and about 0.025 ml is injected. And yeah, what complications can you produce? You can produce a lens touch cataract if you have not directed your needle correctly. You can produce a hyphema or a vitreous hemorrhage. Tangential traction sometimes causes macular hole formation. RP changes at the macula have been recorded, and choroidal ruptures have also been reported post anti-VEGF injection. Now, what are our controversies? We do not have long-term experience with anti-VEGF, and some physiological angiogenesis is also inhibited by the anti-VEGF. Ideal dose is still under trial, we really don't know. Ideal time for administration also. You should do it when the ocular VEGF levels are high, but you cannot do it as prophylactic treatment, so the ideal time for intervention is also still controversial. And why can we not use anti-VEGF monotherapy? So anti-VEGF monotherapy, there is a late recurrence and need for frequent follow-up. All of us who have injected know that once you have injected, the eye just goes into some kind of a dormant state. And then the normal vascularization to proceed takes a long time, which means where you actually finished your laser follow-up babies by 40 weeks, you can send them off and then call them back at 3 months. Here you have to follow up these babies weekly or 2 weekly till they are 54 or 56 weeks, which means such a big baby that I always joke to the sister, this one is ready to go to play school. So that late you will have to follow up because there is late recurrence and late persistent avascular retina. And crunch phenomenon can occur because there is pre-existing fibrosis, which you would have seen as vascularity, and then that whole thing crumples and produces a peripapillary contraction. Risk factors for recurrence are again the same, those who have aggressive ROP, immaturity, and cumulative health issues. So then came the concept of combination therapy. Why don't we give both, give anti-VEGF and then give laser? And there is a possible synergistic effect of the rapid blocking action of VEGF by the anti-VEGF agents and suppression of further production by the laser ablation. And 94% of zone 1 ROP had a favorable structural outcome when this was followed. And it was published by Dr. Parveen Sen, who was here in the hall earlier. And you can use anti-VEGF in combination with surgery as well. Surgical treatment I will not go into because it's going to be covered by Dr. Parag. Now finally, what do I follow in my practice? So the IROP group came to a consensus that you can do combination treatment, which will avoid this long follow-up for these babies. So zone 1 and zone 2 posterior I inject, followed by observation. I am observing for whether there is a reactivation and whether the vascularity is proceeding into zone 2. And what do I inject between Avastin, ranibizumab, and aflibercept? Although we have the BEAT ROP study, after the PGI Chandigarh problem with the Avastin, it is always preferable for you to inject Axenrix because now we have FDA approval. Axenrix, sorry, I have no financial interest. Ranibizumab, because that is having the FDA approval. Aflibercept also, some of the doctors are injecting, but again, we do not have FDA approval for ROP. Now, advantages are that the longer follow-up can be avoided and you don't have to worry about late recurrence, and you're giving the chance for full vascularization of at least the posterior pole, and it adds to the treatment cost of the baby. Once zone 2 is like mid-covered or at least reaching up to mid-zone 2, then I laser the baby, which usually takes about 4 to 6 weeks. And if reactivation occurs before that, you laser prior. If it does not occur, then by 4 to 6 weeks after your injection, you can laser off the rest of the avascular retina. Again, I use the double frequency Nd:YAG in a single sitting. Then on, you can follow up 1 week, then 2 weeks, and you can actually give 6 months follow-up, and the babies do just as well as your lasered babies. This is a refractive error study that we did recently with the different study groups in 4 years. We have found that injection and injection plus laser actually there is an incidence of more myopia than laser alone. So we have not done away with that long-term sequelae of myopia with injection. This first block is just monotherapy injection, which I was doing long back in 2015 when the anti-VEGF started. And those babies are also developing myopia. So you need to do long-term follow-up, whether you have injected or lasered. If your baby has ROP, you need to do long-term follow-up. That has also been covered by Dr. Sheera earlier. So I'll stop with that. Thank you for your patient listening.
Thank you, Madam, for the excellent talk and the excellent work Madam is doing at Amida Institute. Next is the keynote talk of the session. As Manoj sir rightly pointed out, we are very lucky to have Dr. Parag Shah over here. As sir needs no introduction, I would like to say a few words about sir. Sir has graduated from Aravind Eye Hospital, Madurai. After completing his fellowship, he is working as a consultant in Retina Department of Aravind Eye Hospital, Coimbatore, and has developed the pediatric retina and ocular oncology service over there. Sir's main areas of interest are retinopathy of prematurity, retinoblastoma, and intraocular tumors. Over to you, sir.
Good morning, and thank you very much. At the outset, I'd like to thank Dr. Sheera, Dr. Manoj, and the KSOS for inviting me here. And I'll be talking about the surgical management of ROP. So I have no financial disclosures. So vitrectomy for ROP is one of the most challenging problems facing the vitreoretinal surgeons, and we feel this is the ultimate thing to do. But frankly, it is one of the easiest to do. It is much easier to do and compared to an adult if done properly. And why is it easy? Because what you have to do for a lens sparing vitrectomy or any ROP surgery is just do a good core vitrectomy. And just to tackle the traction bands. The traction bands are the lens to the ridge to ridge, ridge to periphery, and the ridge to disc. So this is what all you have to do a good ROP surgery. There is no need for doing any PVD induction, and there is no need to do any vitreous base shaving as we do in the adult for all the cases. Now, why is it difficult compared to the adults? It's just because of the space constraint. The ceiling is down, that means the lens is down, the retina is lifted, the eye is short. So it's a really tight space where you have to go and tackle this problem. Like I said, the lens occupies almost 25 to 30% of the space, and this restricts the intraocular manipulation. And the retina also is elevated, and with a shorter axial length, the space is very, very tight there. So the axial length of the newborn child is only 16.5 compared to 24 for an adult. The vitreous volume is also 1/3. And the ciliary body is actually, there is no sort of short planar existence. It's actually through a the plicator. So it's an entry through the pars plicator. And that is why your entry should be anterior, not as posterior as you see in the adults. And so this table shows that what your entry site should be for any intravitreal injections or even for ROP surgery, and this is according to the age. So we usually take 1.5 millimeter from the limbus for all the ROP surgeries, be it injection or for sclerotomies for lens sparing vitrectomy. And as the age grows, you can keep on going a little bit further away, and by the age of 7 years of age, you can safely go and use the adult techniques. Now, what are the indications of surgery in ROP? So obviously detachment of 4A, 4B or 4-5 or stage 5, but not that all of these require treatment. So when will you operate a 4A? Only when it's vascularly active and it's more than 6 clock hours. But if you see a child with a 4A or 4B that who's like more than 6 months of age, it's stabilized, there's no actually really need to do a surgery. 4B also if it's only vascularly active, and stage 5. Now the timing, the previous speakers mentioned, the phase 1 of ROP starts as soon as the child is born. Phase 2 kicks in by around 32 weeks. And the treatable ROP comes by around 35 to 37 weeks. So it's only around due date, like 40 to 42 weeks, when the VEGF levels drop and the transforming growth factor beta, the TGF-B little levels increase. And that is the ideal time to do surgery, because the traction, the VEGF is less and the traction is the sort of at the peak there, and that is the time you would want to operate these babies. Pre-operative evaluation, obviously anesthetic fitness is required, mandatory, and you have to have an NICU backup. We are in a standalone eye hospital, we don't have NICUs, so we make sure that the adjoining hospital neonatologist has seen the baby, given the fitness, and post-operatively we send the child there for a 1 day for in case any complications arises. Education of the parents, the visual expectations, what you have to tell them, especially for a 5 or a 4B, that the child is never going to see a normal vision like what we can see. The expectation should be like, the stage 5 can get a little better. Stage 4B is always going to be stage 4B. And even if it's settled, there's going to be RP degeneration, the visual outcome is not bad. I mean, it's not going to be very good. And 4A also, you have to be very cautious in telling them that take the risk and the benefit. Always the risk, anesthesia risk is there. You explain to them, anything can happen. All these babies are usually through IVF. They are all sort of, the late pregnancies and precious deliveries. So last thing we want any complication happening because of anesthesia. So you have to really tell them and counsel them. Do an ultrasound, especially for a stage, even for stage 4A and 4B, you would actually get the traction bands where it's maximally present. And before starting the case, it's mandatory to do a good indirect ophthalmoscopy, so that will make you plan where do you put your sclerotomies. In adults, like it just can't go by the rule of thumb that inferior temporal, I'm going to put my infusion, and the superior 2 will be the sclerotomies for the light probe and the vitrectomy. It changes case by case. So the surgical options are for stage 4 is scleral buccal or the lens sparing vitrectomy. Lens sparing vitrectomy is what is preferred. And 5 is lensectomy, vitrectomy, and open sky vitrectomy. Of course, lensectomy, vitrectomy is preferred. Scleral buccal, although easy, it causes a lot of anisometropia and amblyopia issues. And if it's a posterior traction, then the buccal is not really going to help tackling that. So these are some surgeries of the lens sparing vitrectomy, how it is evolved from 20 gauge to 23 gauge and 25 gauge and now 27 gauge. So all this may look very flashy, but the principle is the same. Whatever gauge you use, it is the same. You go 1.5 millimeter from the limbus and you just go and tackle the traction bands. The only difference is in 20 and 25 you do a transconjunctival, you have to do a peritomy, whereas 25 and 27 gauge you can do a transconjunctival also, what you do in the adults. And at the end of the day, it doesn't matter which gauge you use, but your idea should be easy, that you just have to go down, cut the traction bands and come out. And it's always safe to put the sutures, even if you're going at 27 gauge or a 25 gauge. And it's always safe because you can't go back if it's hypotony next day and give the general anesthesia again. A few modifications which we have used in the previously is the tricot assisted vitrectomy. It's very helpful because it just shows you can go very close to the retina and cut the vitreous very close to it, and that is what the aim should be. But the problem here is that the tricot gets stuck so well, it's impossible to remove it, and we have had issues of a few cases going secondary glaucoma in the postoperative period. So now that is what, now we have stopped using it. Now these trocars and cannulas, what the company gives is for adults. And for pediatric, it's very short. So what we use is we make a small spacer before inserting the cannulas inside the eye. And this is a 42 gauge, 42 band, which we cut into small cubes. And we pass the trocar and the cannula through it first for all the three. And then we insert it into the eye, 1.5 millimeter from the limbus. So what happens is it's around 1.5 to 1 millimeter thickness. So it effectively reduces the intraocular part of the cannula, and that saves us from getting a lens touch. And sometimes the traction is so anterior that if that cannula is too deep, you may not be able to assess it. So we are in the process of developing a pediatric trocar cannula with our Orolab company, but this is something which we have tried, but it's still not out. These are some of the pictures of pre and post vitrectomy. Like I said, what you have to do is just a good core vitrectomy. There is actually no need for you to go and remove the membranes and peel off what you do in a diabetic retinopathy. You should not do it, because if you end up with a retinotomy, you're going to convert this 4A into stage 5 ROP. So this is a case where again it was very anteriorly lifted retina, the space was very tight, and we used a 27 gauge vitrectomy, and you could easily go and just cut the traction bands, and at the end of the surgery, if you see this, you should be happy and not feel sad that you have left so much of vitreous membranes there. Now sometimes you see the eyes coming with the 4A and 4B which are active, and obviously you have to do surgery, but then what do you do when these are the two eyes of the same baby? So what we have started doing is bilateral simultaneous vitrectomy, because you can't do one eye, after 2 weeks take the other eye, because it's going to progress to stage 5. And again, the anesthesia risk is high. So this is something which we started doing in 2015, and we have published this. We have done the simultaneous bilateral vitrectomy. And the anatomical and the visual outcome also quite satisfactory compared to what you do in a single eye. And the main thing is endophthalmitis. You don't want to end up with endophthalmitis doing a bilateral case. But again, you have to talk to the parents, tell them about the risk and the benefits, and you have to prep the other eye like you're doing a separate eye of a new patient. Like if the entire team has to de-scrub, you have to wash again, put the new instrument, the vitrectomy tube and all, and restart the case as if you're doing for a fresh case. And we are doing it now very routinely, and we haven't seen any endophthalmitis. And you have to tell the parents to use separate eye drops, right eye and left eye, mark them, and not to mix them, and wash the hands in between. So now it is accepted globally now, not only for ROP, for many pediatric detachments, you can do a bilateral sequential vitreoretinal surgery. Now coming to stage 5, again it's the same thing. What you have to do is tackle the traction bands. The only problem is it is so anterior that it is stuck to the lens. So there is no much surgical space. So you have to go and do a lensectomy. So this is a case, and you have to go as anterior as in the anterior chamber, like a paracentesis. So this is a 25 gauge system where we are going straight away, because there is absolutely no surgical space. Even if you go 0.5 millimeter behind the limbus, you're going to end up creating a iatrogenic dialysis. And here the goal is, after doing a vitrectomy, you try to peel this is a posterior capsule. Again, you have to be very careful not to be very aggressive, because very easily you'll see the retina also coming out because it is stuck so anteriorly. So once you remove the posterior capsule, you have to make a cruciate incision in the center using whatever. It can be a pick, it can be your trocars, and try to extend it as much as possible in the periphery, and using a bimanual technique. Obviously, I mean, you don't require a biome for this, it's very anterior. So just with the light microscope, it is done, and the maximum the assistant can use the light probe from outside. And the whole idea is just to relieve the traction as much as possible and try to open up the funnel. And once you open the funnel, you have to be, there are sheets and sheets of vitreous, so it is better to be a little less aggressive and aggressive, because if you end up having a retinotomy, you cannot settle the retina like you do in the adults, like putting PFCL or fluid exchange and silicone oil. That will be a disaster. And at the end, you can put either Healon or viscoelastic and leave and hope for the best. So this also, we have published the results, and overall success was that time combined stage 3, 4 and 5 was only 15%, the worst being the stage 5, only 14% anatomical success. And what is anatomical success? It's just the posterior pole attached. That we call it anatomical, and the visual outcome is extremely poor. In fact, there are some people say that you should never touch stage 5 because long-term visual outcome is the same as if you don't do a surgery. So like I said, the pre and the post-op, the pale disc, the drag, RP degeneration, and the long-term outcome is extremely poor. So like Dr. Manoj has said, the configuration of the total RD according to the ultrasound, it was open, 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 narrow, a narrow, open, narrow. So what do you do if you don't have an ultrasound? How do you know it's an open funnel? So that is why the ICROP3 came up with the classification of 5A, 5B, 5C, which just shows that if you see the optic disc, that means it's an open configuration. If you don't see an optic disc, it's a closed configuration. And C is with the anterior segment changes, which is an extremely poor prognosis. So you don't really require an ultrasound to see the configuration of this thing. And this is one of the publications by the Japanese group where they have applied this classification in a retrospective manner, and they found it quite useful that the 5A almost had a 90% complete success. We don't see much of 5As. We always see 5B because most of the babies which we do are unscreened, and the parents are referred to us rather than, the parents get to us rather than the pediatricians referring to us. 5B was 40% and 5C was almost 0%. So the staging is quite useful predictor for the anatomical success even for stage 5 ROP. So ROP surgery can be a smooth sailing and it can be quite satisfying, but just we should remember that we are always on the edge of disaster, that at the anterior lens and the posterior retina, and never be overconfident that, I'll be able to do it, because one small mistake and that's going to, change the entire outcome and the life of the child who's going to live there for almost 60 to 70 years. So with conclusion, with modern vitreoretinal surgeries, good visual outcomes and anatomical are possible in ROP and other pediatric VR disease also, but it depends on the time of intervention, anatomy of the posterior pole, amount of anisometropia and amblyopia management. Doing a good ROP surgery is not the end. You have to make the child follows up with the pediatric ophthalmologist, amblyopia management, refractive assessment, and that will be the aim, the end goal. Thank you very much.
Thank you, Dr. Parag, for that excellent talk. So I think as you have already stressed, the surgical outcomes are not always promising in all the stages, especially in stage 5 disease. So the aim is to kind of prevent this from happening. So timely screening and management is a most vital thing in ROP care. Now let's take a few questions. Is there any questions from the audience? Dr. Natasha, I have a question for you. Have you seen any problems, any complications, with laser therapy? Any complications, after laser?
Eye-related complications, no. Actually, I have not seen any. But systemic complication, yes, 1 or 2 babies have had apnea after the laser procedure. I had a death following the laser procedure, but of course it was unrelated, but I went through a lot of trouble trying to convince the bystanders that it was unrelated to the laser. So that is all. Otherwise, actually when the beat ROP came up with this reactivation and recurrence and a high incidence of recurrence following laser therapy, I think most of us found that unacceptable because we don't really have any kind of recurrence if you have done a good laser. That's my experience.
I was asking you this question because now I have encountered at least 2 or 3 instances now where I've seen cataract. Rapid onset of cataract. Parag, you have any comments on that?
So this can happen if you're using a red laser. I mean, theoretically it's the green laser which causes cataract because it will be absorbed by the tunicular vascular lentis and cause it. But if you use a red laser and if you're in high power, it really heats up the globe. And especially if you're doing a 360 degrees in a zone 1, you have to make sure that you go for a grade 2 burn. And we like to do it fast. So what we do is the repeat interval keep very short. What happens is you keep on giving more burns because multiple times, the laser burns go on the same spot, the deep scarring, and that causes a lot of heat also. So that can also cause a cataract, and so you have to be careful of that.
How about anti-risk?
Actually, that child had iris burns and corresponding cataract. Then we waited actually till 6 months, but that cataract progressed and we had to operate on that child.
Yeah, I was just thinking because anti-sequent ischemia can happen sometimes when you do the extensive 360 degrees. Now, I actually had, I was talking to you about a particular patient that I had. This patient, following laser, had a rapid, one patient had a rapid onset of cataract or just 3 or 4 weeks following laser therapy. And another patient developed severe corneal haze. And this patient incidentally also had blood transfusion. And when we looked at some reports, they say that when you have a blood transfusion happening, some of these eyes can have severe corneal edemas. So I just wanted to know if this is in your experience you've seen.
No, I haven't seen, but then one thing what Dr. Natasha said, use normal saline. Don't use distilled water for injection because that is isotonic. You have to use a hypertonic normal saline, so that will keep the cornea. So either use your artificial tears or use normal saline. But the distilled water for injection is very easy. It's 4 ml, and it's already available. But don't use that for your lubrication during the laser.
One problem that I faced during laser is when I got a new laser machine, I found that the pupil keeps constricting while the procedure is going on. Is that because of power as well? I assumed it must be because of the higher heat generated and some ciliary.
No, I don't know, but I haven't seen this. But sometimes the pupil does not dilate because we have seen it before the anti-VEGF era, APROP.
No. These are babies who were dilated well when the procedure was going on, and it was like I've been using the same laser for the last 10 to 12 years. And then when we got a new machine, that is when we realized that I assumed it's because this machine doesn't require as much power as the.
No, I was coming to I have seen the other thing because if you think it's not dilating, you start doing a laser, it will start dilating.
Usually
It will start dilating. Yeah. So you don't have to be really scared that it's not dilating. You give good amount of time for it to dilate. If it doesn't dilate, you start doing the laser.
Yes.
And within a few minutes, it will dilate because of the indentation and this thing.
Actually, I am using viscoelastics on the cornea now, and it's very easy to laser. And nothing happens because we are using it for cataract surgery also. And wash it well before you give the child to the parents because otherwise that sticky thing will be there. So it's very nice to use viscoelastics.
The other thing is, like you see sometimes patients with 4A disease, which are active, you still have neovascularization. So like what is the take on anti-VEGF therapy? How because she also did mention about she said 4B. So 4A, how safe is anti-VEGF therapy in an active setting?
No, as a primary treatment, I will not recommend because of the crunch phenomenon. And you can use it if it's very vascularly active only if you are planning a VR surgery within 24 to 48 hours. But you have to make sure that the child gets the fitness first. He's fit for surgery and then give you anti-VEGF. What happens if you give anti-VEGF and then send for fitness, the child is not fit or child gets sick, child won't come back for a few weeks and then you will actually worsen the disease. So you can use, but then with precautionary thing that everything is ready, the child is fit to be taken within 24 to 48 hours for surgery. Then only I would recommend to go ahead with it.
Okay, the other situation is now you do a laser and then post laser you develop a retinal detachment, a localized retraction at the posterior border of the laser. How do you follow up these patients and how should you, I mean, is there a risk of this progressing or well lasered eye? We assume that that there is no more avascularity that is left.
I mean, the first thing you have to make sure there is no skip areas and make sure of that. And probably if it is a little away in the periphery, I would not hesitate to going two rows in the vascularized retina, like a sort of a, not a barrage, but then sometimes the retina is so elevated that there is some avascular retina below which you are not able to tackle and you just see the avascular retina which is beyond the RD. So once you give a little posterior to it, you are actually going and hitting that avascular retina also which is hidden below the detachment. So that really helps. So, and not as a primary treatment, but then as a secondary treatment, if it's progressing, if it's not resolved, it's still vascularly active, you don't see any skip areas, you can go and give two areas posterior to the, two rows posterior to the detachment.
Published about giving it during primary treatment as well. If you have an area that is completely lifted, just a few clock hours you can do.
The problem is if you're using a green laser, you can cause a vitreous hemorrhage. I mean, you won't cause a contraction like you are scared about DR, but if you hit the vessels with a green laser, you can cause a iatrogenic hemorrhage because of that.
Natasha, one question for you. I mean, sometimes what happens at the end of 40 weeks, we sometimes see patients in, like, say, for example, stage 2 disease. I know they're still remaining stage 2 at 40 weeks or 41 weeks. Now, how do we go about
Stage 2 in zone 3 mostly. I keep following up. I'm not happy to leave them till I'm almost sure that only a small strip is remaining. But I don't usually treat them. They don't require treatment. And I suppose the same theory that we are using for the anti-VEGF, that we should not leave persistent avascular retina. If we are applying, then we should actually laser that area. But most of them do well. Of course, we don't have long-term follow-up because once the baby becomes older, then we are not actually seeing that area because the baby is not cooperative. But since we don't have guidelines for treatment in zone 3, what I follow is to follow up until I'm absolutely sure there is no progression, 2 weekly till around 50 weeks.
Good morning, sir. Sir, we are doing ROP screening at Government Hospital, Palakkad. Get a few patients, like very severe preterm babies, we have been following, and even after 52 weeks, that stage 2 zone 3 remains. Actually, in fact, I have referred some cases to sir. After 54 weeks, it's very difficult to do the screening. So what should we do in such cases?
Yeah, this is exactly what I was asking you, because we actually had we have a small presentation and publication on, we call this smoldering ROP. These ROPs, they do not have the stage 3 disease, but they're still stage 2, and we are worried about this avascularity. And this in our analysis, we did laser in some cases. One surgeon preferred to do laser, another surgeon just observed. And over a period of a year, we actually did not find any difference. What we found is that this stage 2 remains stage 2 till the end. I mean, that's a worry that we have. Later, this avascularity is going to be there, and at some point of time, will they not develop, new vessels and bleed later? So.
A bit of an over treatment, because if you look at historically, we have always had patients when we examine the retina, adult patients, when we examine the retina, there is a rigorous ridge in the periphery. And you say that, your differentials are FEVR versus rigorous ROP, and nothing really happens to them. So,
In my practice, I do that because now our complaints, like these babies come to us for ROP screening and then they don't later come back. So.
That's the amount of avascularity left, and then decide whether you want laser or not.
I mean, I won't recommend laser. I mean, you have to be a little patient, a little brave, and not see very often. If you see every week, no, you'll see that thing and you'll get scared, you'll get tempted.
3 weeks.
Yeah, 3 weeks is good. 3 weeks is good. But I won't recommend doing, unless it is a post-anti-VEGF. If it's a lingering sort of
So
avascular
if it
retina.
stays like that and you keep on seeing for 3 weeks, what will happen? That is what I'm...
No, nothing. I mean, it will regress. It will regress on its own.
Recently, Dr. Divya is one of the patients. They came from abroad, given anti-VEGF, 2 years of age.
Yeah.
So we lasered now under GA.
So that is
so much
different.
of avascular.
That is different. That you
There's
have to
no
be careful.
stage or anything, but...
And especially anti-VEGF, you see even mild tortuosity, then you have to be careful and do a laser. But in case if you see tortuosity without any treatment given and zone 3, you should think about any pulmonary hypertension. Was
we
the
sent
child?
the child to the neonatologist, did all investigations, everything was normal.
Yeah.
But
So
we
it
were
can
worried
be a
to
normal variant also.
Okay,
You don't have to
could be.
be. Sometimes they give sildenafil. Sildenafil causes that tortuosity more in these babies.
Actually, there is a 32 gauge needle available in all the NICUs, which they use for, I think, taking blood from the umbilical cord or something. I'm not sure of the exact use, but
31 gauge insulin needle, sterile, by Dispovan. Only 3 rupees it costs. And it's very nice. And in fact, I mean, I don't want to see any company people are there, but you can split the vial also with that because you can use the dead space. See, there is no dead space in those needles. So just the insulin length is only 6 millimeters.
this 32 gauge is also available. If you just check with your NICU, they have it.
Okay, thank you everyone for this session, attending this session. Now I invite Dr. Manoj sir to give a memento to Dr. Parag sir. Thank you sir, thank you Parag sir, thank you Manoj sir, and everybody attending the session, thank you.